Hello, good evening, everybody, and welcome again to today's meeting. Our usual protocol, I'll just run through a few of the house rules. Please let's all try to stay muted during this period. The mute button is the very first one of all the rows of buttons on the left, just so that we don't distract the presenter. As much as possible, we would, as much as possible, we would allow the presenter to just generally focus on what he's here to do. He's new here, so maybe I should probably start with a bit more of an introduction. This is the NOA Zoom learning sessions, and we're gradually running towards the close of the pediatric bit. We have another few weeks to go. And hopefully at the end of this period, we'll be able to have a bit of like an evaluation session more for the residents, just to give us feedback in terms of what we've done so far and use this as a platform to sort of build on for the next set of pediatric core lectures. We have the chat boxes open, and do feel free to write in your questions at any time. The presenter will pick them up during the course of the lecture. As much as possible, the waiting room is handled entirely by the moderator. So this is for the presenter. Don't think about the waiting room because it tends to freeze up your slide if you do. And internet connection and so forth. People do wander in and out of the waiting room sometimes because of an unstable internet. We have Mr. Roland here in the house today, and I'm really pleased to have him. He's an excellent clinician, a fantastic surgeon, and a wonderful teacher, very knowledgeable. Well, I know that I'm not quite using the things that you sent me on your slide, and why am I so surprised you me that particular slide? I would put it up if it makes you happy, but I need to say a few more other things apart from the fact that, yes, you're a consultant orthopedic surgeon, you look after children at the Royal Hospital for Glasgow. We all know that now, that's written up on the board, but I think you're so much more than that. And I have learned so much just from working with you these last many months. I know that the frames are still a bit of a sticking point.
I'll convert you.
Yeah, no. His interests are, apart from everything else, really, bikes, frames, definitely children with spina bifida. He'll be talking about spina bifida today and a host of all sorts of other things, really. His knowledge is quite broad. And I do hope that you would find time in your schedule, even for subsequent sessions, to teach more and more as time goes by. We would really love to have you.
Certainly.
Yeah, definitely a bit on frames as well and limb reconstruction, because that's something that's growing and definitely still quite needed in Nigeria, since we have all the Browns, we have post-traumatic deformities, and we have a lot of people who are keen to do this. So I do promise to bring you converts for frames, even if I don't do that myself. Well, without much ado, I would probably just hand over to you to start teaching, if that's all right.
Certainly.
Around 5 past, so I think we're on course.
Perfect. Well, that's very, very kind set of words, Kemi. Thank you very much. It's been a pleasure. Well, it's still a pleasure to have you in our unit in Glasgow. Kemi asked me to speak to you today about spina bifida. I am one of 8 in the Royal Hospital for Children, all paediatric orthopedic surgeons, but I'm the one primarily allocated with the spina bifida patients. Spina bifida is a thing that's not enormously prevalent throughout a lot of the UK. I trained in England and I saw maybe 2 or 3 patients with spina bifida. But up in Scotland, we've got a lot more. And we now have a multidisciplinary clinic running once a month where we see all of those patients. My aim today is going to be to talk you through a little bit about spina bifida, to talk about the orthopedic manifestations of it and the orthopedic management of it. I find these things, talking to a Zoom channel, very weird. Please interrupt as we go along. If you wish to ask me any questions, you can put them in the chat box. But if you want to raise a hand on the thing or even just shout at me, my name is Dave. Please do that, and I will attempt to answer any questions as we go along. But there'll be plenty of time at the end to answer anything as we go through. Okay, all good to go. So, spina bifida. This young lady on the front screen here was somebody with spina bifida from Glasgow who competed in the Commonwealth Games. Spina bifida is often a fairly devastating diagnosis when it's delivered to families, but it isn't as devastating as it might have been in the past. We aim to get patients with spina bifida as mobile as we can, as independent as we can, and to give them as normal a life as is possible. Spina bifida is something. My slide's not working. That's a good start. Right, spina bifida. Bifida means split, basically. So a spina bifida is a split spine. It's one of the most common neural tube defects. The other one is anencephaly, and they are both abnormalities in formation of the neural tube. What I tell my patients in clinic, or when I see them on the neonatal unit with this or anything else to talk about spina bifida, I compare this to fajitas. I don't know how much you all like fajitas, but I quite like them. And if you think of that flat flour tortilla that you have, you put all your vegetables and everything else in, because I don't do meat, and you roll it up, and that's how your neural tube forms. And if you don't roll it up tight enough, some of the food falls out. Okay, and a spina bifida is a bit like that you haven't made your fajita in quite the right way. And an anencephaly is when the top end isn't closed. A spina bifida is when the bottom end isn't closed. And it's the bottom end that we're going to talk about today, the spina bifida, the split spine. As far as I could tell from my internet research, the prevalence in Africa is about 13 per 10,000 live births. This is from a 2020 meta-analysis. I don't know if any of you who are in the audience there were involved in that. But as far as I could see from digging into that, in Nigeria, it's about 7 to 9 per 10,000. In the USA, it's down at 3 per 10,000. In the UK, 3 to 6. And that's because down in the south of England, it's about 1 or 2 per 10,000. But up in Scotland and in Ireland, in the Celtic races, it's probably much higher at about 6 per 10,000. We don't quite know why that is. I'll come on to that a bit more in a minute. So let's talk about the neural tube. The neural tube is part of the ectoderm in the middle of your tortilla, your flour tortilla, and from days 18 to 26, it rolls up and it forms a tube, and that becomes your spinal cord. And over the next few weeks, you get your somites adjacent to that to form a bony vertebrae that encases that spinal cord and protects it as you grow older. We all know that. The important thing here is the timing of this. This happens before the mother misses her first period. And that means this happens before she knows she's pregnant. Okay, that's going to come up as an important thing later on. Here is a normal vertebral cord, and you all know this as well. Looking at the top, we've got the spinous processes. We've got the spinal cord sitting in the middle, surrounded by all of its various meninges and everything else. And we've got nerve roots coming out. The most simple form of spina bifida or spinal abnormality that we're going to talk about is spina bifida occulta. This is very common. This is about 10% of the population. And from the outside, there's not very much to see here. You may have a little hairy patch, you may have a dimple, something else. But you've not quite completed that rolling up of the tortilla, and you're missing the spinous process. You may be missing part of the arch at the back of the bony spine, but the spinal cord and the meninges and the nerve roots and everything else around it are all pretty much intact. And so the function of the majority of these patients is absolutely fine. It's often an incidental finding. Somebody will come in with hip pain, get an x-ray of their pelvis. And when you look at the lumbar spine, you'll spot a little gap in the back where the spinous process should be, and that's the spina bifida occulta. 1 in 1,000 of patients with these may have symptoms, and that's if there is a bit of tethering of the cord in the area where that spina bifida occulta has occurred. Where you have these spinal anomalies, these neural tube defects, and sometimes you can get a bit of a tethering or a fatty phylum or something else that holds the lower part of your spinal cord down there. So as the kid grows, the head moves away from the bottom, and that pulls on the spinal cord a little bit. That stretches some nerves, and those nerves don't work so well. As I said before, you can see hairy patches, dimples, other birthmarks, things like that. Here are a couple of examples of that. probably the best example of spina bifida occulta is the Rhodesian Ridgeback dog. That patch of abnormal hair or hair going in opposite direction up their back is spina bifida occulta. These dogs are bred to keep that. But it's exactly the same thing going on here. There is just an abnormal formation of the bony arch, and there's an overlying abnormality in the skin over the top, though it's intact. So the spina bifida occulta patients don't usually cause us too much of a problem. The ones that are more of an issue are the spina bifida cystica patients. And these are the ones where there is more of an abnormality inside. Okay, some of these have intact skin, some of them don't, but there is more missing in the back of the vertebra. And there are a couple of word derivations, bits of Greek, that will explain exactly the different terms that we're going to use. So myelo means spinal cord. Meningo refers to the meninges, the layers of the membranes that surround the spinal cord and contain all the cerebrospinal fluid. Stele is the cystic swelling, and schisis means split. Okay. So a meningocele is a cystic swelling that's got meninges in it. So the cystic swelling that pokes out the back of this child is something that contains the meninges and the cerebrospinal fluid, but the spinal cord is sitting in the right place, in the back, sitting behind the vertebra where it would normally be. So this is a more minor form of spina bifida. This may not need surgical intervention. Moving on, you have a myelomeningocele. And in this, things are more disrupted. You've still got the bulge out the back, but there's skin over the top of it. But as well as the meninges, you've got your myelo bit in there as well. So the spinal cord is sitting in that bulge at the back. And then more severe than that, we have myeloschisis, or sometimes referred to as rachischisis, rachy meaning roots. But in this, everything is completely split and the spinal cord hasn't rolled up into a tube. So we have exposed neural elements on the back. Okay, that's a problem. These are the ones that need urgent cover because exposed neural elements, risk of infection, risk of meningitis. Okay, so this needs urgent treatment. The risk factors for spina bifida are still under investigation. We don't know all of the reasons for it. The genetic component must exist. There must be some kind of genetic component because there are racial differences in this. And in particular, in the United Kingdom, it's the Celtic population, the fair-skinned, red-haired kind of population that affect Ireland and live in Ireland and Scotland, who are the ones who are more prone to spina bifida. But there are differences in different parts of the world as well where this is present. There is a 3% risk in subsequent children if one of your children has been born with spina bifida, and so there must be some kind of genetic component there, but it's not yet been identified. There is an increased risk if the mother has maternal diabetes, and the worse control of the diabetes, the higher the risk. So it can be up to 10 times increased risk of spina bifida if that's present. But by far the most important thing is folate. Folate is vital for the formation of the neural tube. And there have been endless studies showing how good folate supplementation is at preventing spina bifida. But despite that, there are still plenty of places, and the UK is one of them, where we don't supplement flour or other things. It's supplemented in the United States, and they've seen a rapid drop in the number of patients with spina bifida. But because of various different reasons and enabling people's choice and all kinds of other things, we don't yet supplement it in the UK. Now, remember how we said before that the neural tube forms before the mother misses her first period. That means that she doesn't know she's pregnant while the neural tube is forming. And so anybody who's considering pregnancy ought to be taking a folate supplement. That's the guidelines nowadays, that everybody should be taking 400 micrograms of folate while they're planning a pregnancy. They should continue it for at least 3 months after conception until all those neural elements are formed. If there are any other risk factors like the maternal diabetes or family history or anything else, then it's recommended that a much higher dose is taken. The anti-epileptic drugs will compete with folate and upset the formation of the neural tube. And so ideally, those medicines should be stopped before conception. If they can't, then it's very important that a large supplement of folate is taken. Okay. So how do we find out whether anybody has a child with spina bifida? An antenatal diagnosis is very useful for all kinds of things. We already know how wonderful antenatal diagnosis is to be able to talk to families about clubfoot treatment and everything else. Being able to explain to a family beforehand that they have a child with spina bifida, and to be able to tell them what kind of outcomes we can expect from spina bifida is very useful indeed. And for a child to be born and the spina bifida diagnosed just at birth is quite a devastating diagnosis for a family. If we can tell them about it beforehand, it's much more helpful. So the fetal anomaly scan is a non-invasive, useful test. And sometimes you can see an obvious bulging sac like that on the back. You can spot a difference in the abnormality, in the formation of the spinal column or the bony structures at the back of the spine. And ultrasound will pick up an awful lot of things. The other thing is a simple series of blood tests. The alpha fetoprotein does cross the placenta. A small amount of it can be present in the maternal blood. If there is a neural tube defect, then the levels are much higher, and a high serum alpha fetoprotein in the maternal blood would indicate further investigation to be worthwhile. Those further investigations are probably going to be an amniocentesis, but like any other investigation, that needs to be discussed very carefully with the family before proceeding. And really, we want that diagnosed before we have a child born with that. Now, diagnosing it beforehand is not going to stop the child being born with that, but it means that we're prepared for it. It means that we can plan when the delivery is going to happen. It can be done in a tertiary center where we can have all the appropriate specialties nearby and able to deal with it. We said before that if you have open spinal elements like that at the back, then there is a high risk to this child, in particular of meningitis. And so the immediate management of it is to cover it up with cling film or something else. Covering it up with cling film means you don't have to keep disturbing dressing, is to have a look at it as each particular specialty comes past. In our hospital, it was the general surgeons who looked after these, but increasingly it's the neurosurgeons and, if need be, the plastic surgeons to mobilize skin flaps to close the skin and the meninges over the top of the spinal elements. That increases the chance of getting decent closure over the back and reducing the risk of infection there. This child has anomalies, so we have to look everywhere else in the child for any other anomalies. At the same time, you can get the urologist in to have a look at them too, because spina bifida affects your lower lumbar nerve roots and your sacral nerve roots, and the lowest of those are the ones that are going to be looking after your bladder and bowel. So nearly all of these patients have problems with bladder and bowel function as well as any other manifestations. So as soon as a child is born in our hospital, orthopedics are alerted, neurosurgeons and the urologists all take part. And we're the ones who run the multidisciplinary clinic as well. The other thing that the neurosurgeons will be looking out for is hydrocephalus. About 80% of patients with spina bifida have hydrocephalus too. And that is because of the tethering of the cord distally in the region of the spina bifida. And as the child has grown, the spinal cord pulls the brain down within the skull, and you get an Arnold-Chiari type 2 malformation, where the cerebellar tonsils are pulled through into the foramen magnum, and you get some obstruction to the flow of CSF. And so it needs to be picked up early. It's difficult in neonates to pick up a hydrocephalus. It can be obvious. They might have a lot of swelling in the head. They may have a bulging fontanelle, altered conscious level, but it's one of those things you need to be aware of and look out for, always be looking out for it. If this is picked up later and the children can communicate with you and tell you about things, then headaches, visual disturbance, reduced coordination, and other things are an indication that there may be hydrocephalus, or if they've been shunted already, that the shunt might be blocked. The usual treatment for this is to pop in a shunt from the ventricles down into the peritoneum to drain it. From an orthopedic point of view, what we want to do, we're not going to be involved immediately, but as soon as the child has been stabilized and the skin cover over the back is all right, then I get called to come and have a look at the child. And what I'm looking for is to see the lowest functional nerve roots. So I'm looking to watch the child, see how much they kick, see how much they move the legs in each of the different directions, see what function they have. I'm going to look everywhere else. I'm going to tickle their feet to see if they can feel that. You'll all know how difficult this is in a child, but particularly an infant. But we're going to try and assess all that and document it. I'm going to look at all of the joints and see if there are any fixed deformities, anything that needs addressed early on. I'm going to ultrasound the hips of every one of these children that I come across. The physiotherapists get involved early on. They have a very extensive series of charts for muscle charting, and they record things very nicely. And they also explain to the family about positioning of the children and how to stretch in case there are any kind of contractures. I'll explain about contractures in a minute. Orthotics are not usually involved early on, but if the child has a large lesion on the back or the shape of the spine is difficult, then sometimes positioning the children can be difficult. And so our orthotics team can offer different kind of postural supports if need be. So talk about level. Spina bifida level means different things to different people. The neurosurgeons will talk about an anatomical level, where exactly in the spine the lesion is sitting, if it's thoracic, if it's lumbar, is it an L1, L2. From an orthopedic point of view, though, I would be more interested in the functional level. And the functional level is the lowest functioning nerve root in these children. This spina bifida manifests itself as lower motor neuron lesions. They do not usually have the increased tone. It's a floppy paralysis of the lower limbs. And they will be paralyzed below the level where the lesion occurs. I'll talk more about that in a minute. Okay. It may not be symmetrical. It's often not symmetrical. And sometimes you can get skipped lesions. You can get a patch where there is some kind of abnormality in the spine. And it can be that you have a functioning L2 above, L3 isn't working, but L4 or 5 may have some function down there. So as you work down systematically, if you come across one that's missing, don't stop there. Keep going and look for everything else as well. And the sensory level may be different to the motor level. So I tend to work down the motor level and then work back up the way in a sensory approach. Now, apologies if this is all a little bit simplistic, but this is the way I think about things. And nerve root function gives you these things. So L2 is going to be your hip flexion. You know what hip flexion is, but I enjoyed making that diagram. I hope you enjoyed it. L3 is going to be your knee extension, and L3 function gives you the ability to lock your legs out. And if you can lock your legs out, then you can stand on them. L4 is a bit of hamstring function, so knee flexion, and it's also ankle dorsiflexion. Okay. So the more of these nerve roots that are functioning, the more you have control over the shape and position of your limbs. L5 is where hip extension starts, okay? And great toe extensions in there, of course. Okay. But it's not until you get to S1 that you have power and ankle plantar flexion. And you need power and plantar flexion to push down against the ground so that you can hold your shank up straight and you can get your ground reaction force to pass in front of your legs. So we must never forget the other plane as well. L2 and L3 function are going to cause hip adduction, but it's not until you get to the lower roots, L4, 5, and S1, where you have hip abduction power. And it's hip abduction power that gives you the ability to stand on one leg with your pelvis level. So an example for this, or the way to think about spina bifida, the way to think about what's going to happen to a child's leg is which nerve roots are functioning. Okay. Spina bifida is, as we've said before, a floppy paralysis in some areas. And so that floppy paralysis causes a lack of balance. And if you've got all your nerve roots functioning, everything is balanced, you can move your legs where you want to, and you can do whatever you want with them. If you have some nerve roots working and some that aren't, then the ones that are working are going to overpower the ones that aren't. So an L3 example will have hips flexed because they have no hip extension power. They'll have extended knees because they have no knee flexion power, but there'll be no power below. They'll have no control over their ankles, and so they can't control how that foot responds to the surface underneath them. And they will tend to go into a bit of hyperextension at the knee and be leaning forwards over their feet. Our aims of management are, in basic terms, to try and correct that imbalance. You want to try to provide a stable extension posture. And so that is about positioning your legs or allowing a range of movement at the limbs so you can get your ground reaction force to help lock your limbs out. So in the example here, we've got a patient with hip flexion contractures who is requiring crutches to balance. If we can get them to stand a bit straighter by stretching out their hip flexors or even lengthening the hip flexors and trying to arrange it so that the ground reaction force passes in front of the knee, then that can help to lock the limbs out to enable them to stand. And if we can get them to stand without having to hold something in their hands so they then have their hands free to interact with the space around them, so much the better. Okay. There are plenty of patients with spina bifida who are not going to be able to be up and standing for their whole life. But the more we can get them standing from as early as possible, the better it is for their bone stock. You all know how bones are respond to load by laying down further calcium. And if we can load these bones, we decrease their fracture risk later on in life. It's also much better for their chests, and it's much better for their bladder and bowels as well, to be able to be standing or to be able to change position more easily. Having said that, we've got to have realistic goals for these patients. Children with thoracic lesions will not walk as adults. Children with lumbar lesions may well walk if they've got good quads. If they can lock their knees out and they can have their limbs as a stiff post underneath them to balance on, then they'll be walking. But they may need some assistance. They may need a stick or they may need crutches. But over longer distances, particularly as they get older and as their weight outstrips the strength that the limbs can provide, they may well need to go into wheelchairs or other mobility aids later on. Those with sacral lesions probably will have need for minimal assistance. If you've got S1 power, then you've pretty much got normal lower limbs for walking. But all of these will have bladder and bowel problems as well. And so the urologists need to be involved as well. And again, coming back to basic principles, what we can do in orthopedics is not provide extra strength. We have to deal with the strength that is there. And we have to supplement whatever is there by either stiffening a joint or providing an external, by stiffening it internally or externally, by providing a splint to help hold something in the right position. And I would much rather use a splint than internal fixing because I want a bit of movement at the joints. If you have a force that's predominantly overpowering, so if there is somebody who has a spectacularly tight set of hip flexors that's causing them to bend over forwards a lot, then maybe the only way to get them standing upright is going to be to release those hip flexors. We'll talk about hips a bit more as we come along. Our aim for feet and spina bifida is the same for any other feet, that we want supple plantigrade feet. And supple is good because these may be insensate feet. And if they are stiff feet that are meeting the ground in one particular position, then there's a high risk of pressure sores. And pressure sores in spina bifida, not a good thing. I tell all my patients to get a mirror and put it on the floor of the bathroom so they can check their floor, check their foot sole as part of their daily hygiene routine. But if they are getting real problems with pressure issues, then they can be very difficult to heal, and in a small number of patients might well even lead to amputation. Hyperextension at the knees and at the hips allows you to get your ground reaction force in front of those joints to be able to be up and standing. Okay. So for any multidisciplinary management of spina bifida, you need to get to know your orthotists very well. We're very lucky at the Kids Hospital in Glasgow that we have excellent orthotists on site. And they often come along to the clinic as well, or if they are not available at the time, it's a 2-minute walk from the clinic, carrying a pair of splints around to go and see them, and they'll address things for us straight away. Like any splinting, you want to splint as little as possible to allow as much function of things that are present. But so the most simple splint that we may use in spina bifida is an ankle foot orthosis, top left of that screen, for somebody who has missing S1 power. If they've got something has just pinged up on the screen. Sorry, is that somebody trying to ask me a question?
No, it says your slides are no longer being seen. I can still see your slides, so maybe it's a local network problem with this person. So
it's back.
Yes, it's a local thing with one person.
The slides are back. It's he's replied. You can see it as well. Excellent. Good. Okay. We're talking about splints. Yeah, splint as little as is necessary to give the limbs, to give stable limbs to be able to stand on. So top left here is an ankle foot orthosis. Coming down from that, we've got a knee ankle foot orthosis, and I don't know how well it projects, but you can see that there are levers behind the knees. These levers allow the patient to lock the knee out in extension so that they can be up and standing, and then they can click to undo the hinges so they can easily get into their wheelchair or sit into a chair with their legs underneath the table. The less function they have in the lower limbs, then the higher the splint needs to go. In the middle is a hip, knee, ankle, foot orthosis to control hip function as well as knees and ankles. And you can see there are no hinges in those knees anywhere, because that's a standing device only, and that's for a patient who has no control over their knee function at all. The thing on the far right is a fantastic device. That is a reciprocating gait orthosis. That child has very limited function in their lower limbs. They've got control with the splints over their ankles. Their knees are locked out straight with the hinges on that device, but you can see a pivoting thing that sits over the sacrum. And with trunk control, as you lean your body to one side, that causes a flexion movement to occur in the opposite hip. And so you can alternate hip flexion from one side to another by pivoting around your waist using your trunk muscles to flip from one side to another. And that allows a reciprocating gait. It's quite a difficult thing to learn to use. Not every child can manage it, but from the age of about 6 or onwards, if somebody's got L2 level, so a bit of hip flexion there or a bit of control over the trunk, then we'll try those. And it does give a little bit more independence. Now, wheelchairs are not a failure of treatment, and that's a difficult thing to explain to some patients, particularly the young patients who have been mobile and are starting to reach a point in their life, usually sort of 10 to 12 years of age, where they're suddenly not keeping up with their friends. They were able to be a bit more active, but they're now getting taller, they're getting a bit heavier, they might be starting puberty and their body's changing shape, and they don't have the strength in their legs to be able to do quite what they used to in the past. You give somebody a nice lightweight wheelchair, then they can be as mobile as their friends. They can keep up with their friends. Society is much better at dealing with people in wheelchairs nowadays. This is an example of somebody who was part of the wheelchair netball team. You saw on the first slide, I presented somebody with an adapted wheelchair for the wheelchair racing. And there are many different options for wheelchairs nowadays. And for a certain number of patients, a wheelchair is going to be the appropriate treatment. And quite often the child will come in and say, actually, thank you very much. I've tried everything. I can't keep up with everything. Please may I have a wheelchair? And that's absolutely fine. There is evidence, however, that if we've been able to get people up and about on their feet and standing for periods during childhood, then they do slightly better later in life because of the better bone stock, the bowel function, everything else like that. So let's talk about surgical options for things. We'll start at the bottom and work our way up. When kids are born, their foot shape may be abnormal because of the lack of balance in their muscles. And so you may see traditional clubfoot deformities, and you may see calcanea valgus kind of deformities. You can see all kinds of different deformities. What we want is a nice supple plantar-grade foot, and so you can address that with serial casting. Serial casting in spina bifida, though, is tricky. You need a nicely padded cast because the sensation is not great. And you can't always tell if the cast is causing a problem. So you shouldn't leave the cast on for too long. You can follow a standard Ponseti kind of regimen for everything, but bear in mind that there may be an imbalance in the musculature afterwards, and so the risk of recurrence is higher. I would aim to get the foot cast round into an appropriate position in a standard technique, but if the muscular function in the lower limbs is not great, if they haven't got any S1 power or if their knee power isn't particularly good, then the boots and bar don't work particularly well because you need to be kicking your legs to be able to get the boots and bar to help manipulate your feet properly for a standard club foot kind of treatment. And so I would often go not for a boot and bar, but for an ankle foot orthosis at an earlier stage. We've tried a couple of times with the abduction dorsiflexion mechanism boot, but have not found any benefit of that over a standard ankle foot orthosis. We tend to prefer soft tissue intervention for feet to try and keep things supple. Bony surgery is really a last resort. Tendon transfers are something you can consider, but you need to make sure that you have all the normal prerequisites for any tendon transfer. And so you need a power of at least 4/5 in any muscle you're thinking about transferring. And if you've got a mixed set of strength in the lower limbs, then a tendon transfer may not always be the best. There are a few that may be useful. I'll talk about one or two of those in a minute. What's more common is just to remove the deforming force. And so I'll show you a picture here. There's a calcanea valgus foot. This is the classic pistol grip kind of deformity that's described in spina bifida L4 level. So L4 is functioning, tib ant is working, it's pulling the foot up. And they rest on the heel. The skin over the heel is not, on the back part of the heel is not always as well adapted as the skin on the sole of the foot. So they often find that the skin there is cracked and dry. It needs moisturizing. What we'd like is a nice supple plantigrade foot. So one tendon transfer that has been described in spina bifida is to take the tibialis anterior, pass it through the interosseous membrane and attach it to the Achilles tendon remnant, or even put it through a drill hole in those calces. I've done that in one patient. He's delighted. But there are a couple of other patients in whom it wasn't really ever going to work. And in those, they had too much of a contracture. The skin wasn't great around the heels. What we did for them instead was an approach across the front of the ankle, and we took every single ankle dorsiflexor, all of their toe extensors and everything else as well, to give a supple foot that would sit at 90 degrees and could be put into an ankle foot orthosis in an appropriate position. The cavo varus foot is a problem. If you've got a nice functioning tibialis posterior, but you've got no eversion power, then drifting to cavo varus is something that you do see. This young girl, you can see how multiply scarred she was on the right side. She'd had a number of procedures, soft tissue releases and deirritation osteotomy and a variety of things. You'll notice that she's only got 4 toes on the right foot because she walked on the lateral border of the foot and had pressure sores and infections and had a ray amputation on that side. She was due to be having another posteromedial release of her ankle to try and improve position. But the skin on that side was woody and hard and would not have responded to any kind of release. So here's my obligatory frame picture. We treated her with an Lizaroff device and gradual soft tissue distraction. And with that, we were able to get her plantigrade. It took about 3 months to gradually stretch everything out. And it was very nice for at least a year until she recurred again. These are difficult problems. Try to avoid excessive scarring if you can, because scarring contracts, and going back through a contracted scar is much more tricky than going through virgin tissue. The get out of jail card is a triple arthrodesis. And by that, you've got to take away the standard tailondivicular joint, the calcaneal cuboid joint, and the subtalar joint, and stiffen the foot, the hind foot, into a position. I would try to keep the ankle mobile if possible, and if we can leave the middle part of the foot mobile, so much the better, so that there is some possibility for the foot to move within the splinter on ground when they're bearing weight through it. But a triple arthrodesis like that will help to shorten the skeleton within the soft tissues and gives you a little bit more flexibility. So the knees, in spina bifida, it's nice to have hyperextension of the knee joints. If L3 is functioning and L4 is not, then they often go into a hyperextension. Then you can lock your knees out into a bit of hyperextension. The foot's planted on the floor underneath, and the ground reaction force passes in front of the knee, which tends to put you more into extension. And you can lock your leg out against the back of your knee to be upstanding there. One of the things that can happen in spina bifida, though, is that the non-functional muscles contract. And if you end up with a contracture in the knees of more than about 15, 20 degrees, then it's very difficult to get the ground reaction force in the appropriate position. And the surgical options there are really to go and do a full extensive posterior release of the knee. And when we say extensive, I mean, that's everything that isn't the neurovascular bundle that goes. So I did one of these last week, and we released the hamstrings, the gastrocnemius heads, the posterior capsule, the posterior cruciate ligament, the medial and lateral collateral ligaments in the posterior half, and everything until the knee goes into about 10 degrees of hyperextension. They then go into extension splints for approximately 6 weeks, but we change those plasters every week to make sure they're not developing pressure sores underneath. And once that's been done, we can then get the children up into a standing frame. There is, however, a high risk of recurrence in this, particularly if this is a child who is largely in a wheelchair, because if they're sitting in a wheelchair with the knees flexed, they're going to recur. So they need to be aware of the need to keep the knees stretched out and to have the ability to be into a standing frame or to be seeing a physiotherapist regularly to maintain any extension that you have achieved. Moving up to the hips then, we would like hip extension. again, so that you can get your ground direction force in the appropriate kind of position, and you can sag backwards against the anterior part of your iliofemoral ligament. The children who are wheelchair bound tend to get hip flexion contractures, and that's no great surprise. And surgical release of hip flexion contractures is very unrewarding. You have to go in and release the whole capsule. You take psoas, everything else. But because these children will need to go back into their wheelchairs very soon afterwards for mobility, they tend to recur. And counseling the patient before going through any kind of soft tissue release is very important. Very high risk of recurrence in that. But if you're going to be going after the knees and the feet and everything else, there's no point having completely straight legs underneath the hips if you've got a 30-degree fixed flexion contracture at the hips. So you can stand on straight legs, but they're bent forward over a table. That's no use. You need to have the whole lot straight. There is an issue with dislocation of the hip in spina bifida. The first thing, or the primary thing to say about dislocation of the hip in spina bifida is that this is not the same as dislocation of the hip in cerebral palsy. This is a floppy paralysis of the hip that allows the hip to drift out. And remember that you don't get your hip abduction power until we're talking about L4, probably L5 really, before you actually get hip abduction power. And if you've got no hip abduction power, you've got nothing pulling the ball into the socket. And you've got overpowering L2 and L3, which are going to adduct your hip and make the hip drift out proximally. The good thing is in spina bifida, the ability to mobilize is not related to whether the hip is in joint or not. I have plenty of patients mobilizing in Argos and other devices who have bilateral hip dislocations. And these hips, because it's floppy around the hip, they do not develop that same intractable pain that a dislocated hip in cerebral palsy gets because of the contraction of the abductors across the hip. You don't see the ulcers on the top of these hip joints. They just sit out and flop out into a position, and they form their own soft tissue pocket up adjacent to the hip joint, and that's enough. What to do about the hips largely depends on the functional level. If they have L3 and have good control over the knees, and one hip is out and the other one's in, I would probably go after the one that's out to try and keep it in. But if it's only L3, they've not got hip abduction, and there is going to be a big chance that hip is going to drift out again. If they are bilaterally dislocated, I would leave them be, and that's whether they've got L3 or not. In a unilateral dislocation in a child who's got a functional level that's thoracic or above L3, you'd need to persuade me quite hard to put one of those hips back in, because the chance of it coming back out again is very high. The only real reason to put it back in would be for sitting balance. Here's a patient who has spina bifida, and you can see on the right side how the hip is subluxating proximally. There's a very shallow acetabulum on that right side. The hip is migrated proximally. This child has actually had previous surgery and a previous varus derotation osteotomy and Degar osteotomy to try and bring the hip into the right position, but he had no power in L4 or below and no abduction power, and the hip just drifted back again. So we counseled him about various different options. He went back to theatre for another varus osteotomy and a Degar, and that held the hip in for a year or two, but after that it started to migrate again. And after it migrated again, it was painless, but it was seen on radios. We have elected not to take it any further. So we keep moving up. Next we come to the spine. Spina bifida and spine surgery are not a good combination. The thin skin over the back of the spine in spina bifida means that coverage over the metal work and the implants is very difficult. And also operating through the area of the spina bifida defect, where the skin cover has been in the past, is very tricky. Getting any of those scars to heal is fraught with complications. So not bracing, wheelchair adjustments, various other things. And the majority of patients, that's quite enough. If you are going to go and fix the spine, then it needs to be a long fixation usually, and it often requires fixation all the way down to the pelvis. Because the posterior elements of the spine are not great, then you often need to think about some kind of alternative to using pedicle screws, because the pedicles are not always great. And so an anterior fusion may well be a better option than something posterior. Having said that, you can do good things. I didn't do this. I don't do spines. This is one of our patients who was treated by the spinal team from Edinburgh, who had a large lumbar kyphosis, which was excised and straightened. And you can see the massive difference that's been made to that child. They were getting regular problems with skin breakdown over that gibbous in the spine. And after the surgery, much straighter, the few extra inches of height that they were given by it was a huge improvement for the child as far as they were concerned. They were still in the wheelchair, but they felt much better being able to sit upright and have their hands free to be involved in everything else. Some other general surgical principles. For a lot of these patients, you don't need general anesthesia because they're insensate below a certain level. So I certainly recall doing bilateral Achilles tenotomies in a girl who talked to me at great length during the operation, and then talked to all of the nurses as well. And we tried to be involved, tried to assist, but we didn't let her. We just carried on and did everything. She was very nice, still is very nice. There was always in the past a risk of latex allergy, largely because of the need for these patients to be catheterizing regularly and using latex catheters. Latex catheters are now not so commonly used, and so the latex allergy thing is not such a common problem. But because of the risk of latex allergy, these patients tend to need to go first on the operating list and are treated as though they're latex allergic. That abnormal skin on the spine doesn't respond well to being supine for a long time. And so careful patient positioning, padding, and regular checks during long procedures are sensible. And if you're putting any of these patients into cast afterwards, then you ought to take the cast off every week to check the skin underneath. The other time they come and see us in orthopedics is for fractures. I remember that these are insensate limbs, and so they may not have felt the fracture. And it's not at all uncommon for them to present with a hot red limb that's thought to be an infection. And so if you see somebody with spina bifida who's got a hot red leg, I'd get an x-ray first, because this was sold to our registrar as a septic arthritis, but is clearly not. You can see a fragility kind of fracture here. This was a wheelchair-bound patient who had been completely unaware of what had happened, but had noticed some progressive swelling and redness around the knee for the last week or two. The process of treating these fractures is exactly the same as anybody else. They heal in exactly the same way, but again, because it's somebody being treated in a plaster, beware of pressure sores under the cast. And so if you can manage in a removable splint to allow inspection of the skin, then that's much preferable. He was managed in a removable knee splint and went on to heal like this. Much like the head injured patients, spina bifida patients throw down a huge amount of callus everywhere and heal very, very quickly, often a little quicker than somebody of the same age without spina bifida. Okay. That's pretty much it for me there. Spina bifida management is very much a multidisciplinary approach. It is a good thing for us, I think, in our hospital, the way we run a multidisciplinary clinic. We have the neurosurgeons, the urologists, and orthopedics all present. Orthotics are just around the corner. Everything else is available on site. And it's good that the patient only have to come up once to see all of us, but even better is that these clinics are for all of the spina bifida patients in the area. So they will be catching up with people with exactly the same condition at the same time. And I think I do like that. I like it when patients meet up with each other and can talk about the pros and cons of one thing they've tried versus something else. And there are some very basic principles. Okay, you can supplement existing strength, remove the opposing forces, but you can't give any extra strength. And where possible, try and maintain the mobility of any joints to limit the consequences of pressure sores. And we do all of these things to try and encourage the independence of the patient. And really, spina bifida is not the life sentence that it was in the past. With all of the adaptations that can be made with wheelchairs, advances in orthotics and everything else, there really is a lot of hope for these children. I think that's my bit. Please ask me lots of questions.
Thank you very much. I suppose we just wait for people to pop in questions into the chat boxes.
Perfect.
Yeah, we'll see how that goes. I think perhaps one of the big differences I have noticed with me going through training in Nigeria is the fact that the spina bifida patients tended to sort of hover around the neurosurgeons because they pick them up at birth and they fix
Yep.
them. Somehow there really wasn't such a lot of orthopedic input. Now, perhaps the way forward would be for us to join the neurosurgeons and offer help, and just at least offer to sit in with the clinics and assess the patients and start seeing what can be done in that.
It is very helpful to have the neurosurgeons available to be able to talk about patients. So let's give a couple of examples. I've got a child at the moment who had failed to attend a number of appointments, but then the mother rang to say that she felt that her daughter's foot was deteriorating. And certainly the girl is now in a bit of equinus. She has no power in abduction on that side. And there has been a change in the function around her ankle. Now, from an orthopedic point of view, it's probably something that's going to be amenable to tendon transfers, maybe a tendo Achilles lengthening. But actually, it's not right to do it yet, because the reason that girl's foot has deteriorated is that she has tethering of her spinal cord. And there is no point going and addressing the tendons and their imbalance around the foot if you haven't removed the primary cause for it, and that's the tethered cord. And so we sat and examined this with the neurosurgeons as well. The neurosurgeons repeated her MRs, had a look at everything else, found some evidence of stretch, and have taken her to theatre and have done the surgical release of her spinal cord. And so I'm going to wait 3 or 4 months, let everything settle down from that surgery, and then we'll see what we're left with. And then we can deal with whatever is left with whatever is functioning still. But to have gone in before releasing the cord would have meant that the risk of failure of our surgery would have been much higher. There's a question there.
Yes.
Yes. What's my view about intrauterine closure of spina bifida? I knew that was going to come up. As soon as I finished the talk, I thought, oh, where's the slide about intrauterine closure that I'd meant to put in a couple of days ago? So intrauterine closure is a very new thing. We have one patient in Glasgow who's had it, and they had it performed in Belgium. The National Health Service in the UK is now funding for some patients to be sent across to Europe to have this done. There are some centres in the States that are doing it as well. Certainly the outcome seems to be a lot better for these children if they've had the lesion closed in utero. Quite how you explain that is a little tricky, because the formation of all the nerves and everything happens in the first month or so of pregnancy. And there is currently a suggestion that there's a sort of 2-hit thing. You have your initial hit when things are made, then you have a second hit when the child's born and everything is exposed to the fresh air. And if you can get it all treated while they're still in utero and while things are developing and growing more rapidly, then the function may be better. And certainly intrauterine closure, I think, is probably going to be the future. The child that we have here, who had a sort of L2 anatomical level, has pretty normal function throughout their lower limbs as a result of having had an intrauterine closure. It's not easy surgery. It carries with it significant risks. You all know that the risks of an amniocentesis are not inconsequential. And to actually go through and try and operate on a fetus, that's pretty big stuff. But if you know what you're doing, and the centres that are doing it do know what they're doing, then the results seem to be pretty good.
I've got a question, David.
Certainly.
Thank you very much for taking the time out to give the talk. It's Sanya Adidapo from Middlesbrough speaking.
Hi, Sanya.
Very well, thank you. It's delighted that you were able to take time out to teach our folks. Thank you very much again.
Oh, not at all. It's an absolute pleasure to be asked. Thank you very much.
I have a few questions. Most of the audience consists of the residents all over Nigeria. So Kemi's kindly with her colleagues put together this, and some of our colleagues are also on it as well. So they might want to ask or type questions in, and I'm hoping that you'll be able to help us with this in the times to come. I've got a few questions.
Sure. Yeah.
Like Kemi alluded to, one of the problems we have is that most of these patients end up with the neurosurgeons. in Nigeria, and they often don't see an orthopedic surgeon until they've got some quite severe foot deformities, or they come in with pressure ulcers, pressure sores, and festering ulcers when they've been walking on insensate feet. Two questions. The first question to ask is, I hear what you say about getting an MRI scan and picking out tethered cords and syringes sometimes.
Yeah.
Should we, sometimes it's difficult to access the neurosurgeons immediately. Should we be doing these scans before we do anything to the foot, so that at least if we see anything, then we can alert the neurosurgeons to it and stop whatever we're doing? That's my first question.
Okay.
Then the second question,
Okay.
as far as the foot deformity is concerned, I think there's still some school of thought that believes that you can correct some of these spinal bifida deformities with manipulations and casting. What is your opinion with respect to that? I mean, somebody's actually is interesting. Somebody's just put a question up about clubfoot correction with Ponseti casting in spinal bifida patients and things like that. What do you think about it? Because I think it carries its own risk, but I'd like to hear what your opinion is. And then my last question is on urology care.
Third one.
I know you haven't. You better write all this down. I know you haven't mentioned urology care because you're not a urologist, but I'm hoping that, given that you come from a center where we don't see a lot of this in Middlesbrough. My patient load is minuscule when it comes to spinal bifida. I've seen some, but I think that we get folate here. I don't know whether you don't get it there. So the first 5 years of my practice, I saw some, and then it disappeared. I don't have anybody new now. So with the urology care, especially for my colleagues that are having to look after pretty much everything on these patients when they see them, do you have any particular advice as to what are the sort of things to look for and what are the sort of things to do for these patients? Thanks. Sorry, too many questions.
That's fine. That's fine. Okay. So the first question was the MRI question. The MRI questions, in my experience, so the kids who are just born and have foot deformities, well, those kids who, if they've got an open lesion sorry, start again, in our center, they will have had an MR, a feed and sleep MR in the first couple of days. If they're going to theatre to have a lesion closed, or even if it's a closed lesion, but there's an obvious saccule abnormality in the lower limbs, then they get an MR very quickly. Feed and sleep rather than a GA or anything else is easy enough to do. If they've been to theatre to have the lesion closed, then the neurosurgeons are going to have released everything they possibly can do around that stage to get on and get the skin closed over the top, leaving a mobile cord underneath. And any foot deformity that we're left with is something that I would treat with manipulation. And I would treat that like any other clubfoot or a calcanea valgus, although a lot of the calcanea valgus feet in people without spina bifida, I just watch. But the more severe ones, I would cast and do reverse Ponseti type of techniques for those. And serial casting, but I would change the casts at least weekly. I'd maybe change them every 4 or 5 days or so, just to make sure that I'm not getting pressure sores underneath. Because you know where you're placing your thumbs and pushing on anything for serial casting, you don't want to leave too much of a dent anywhere because it's fragile skin. They can't feel anything, and there is a risk of getting the pressure sores underneath. And so I would try serial casting for these wherever possible. The ones that where I talked about getting an MR before intervening with tendon transfers and things, those are the kids who are probably around the age of 10 or 11 or so, who are going through their pubertal growth spurts. And it's when something suddenly changes at that age that I would think carefully about getting an MR of their spine before going on and doing any tendon transfers then. Does that answer that? Is that the MR question? Was that question one? Is that enough for question one?
Yes, it answers it. And I think that it would probably alert people to do the scans, even if you were seeing the patient for the first time.
Yeah. I don't think there's any harm to getting an MR. I know it's very easy for me to say that because we've got hot and cold running MRs easily accessible, and I understand it, and it's not always an easily accessible thing, but I would hate to go ahead and do something without knowing exactly what was underlying it. In terms of Ponseti management, then, I would standard Ponseti type of cast, above knee plasters. plaster of Paris, everything else, tenotomy in exactly the same way. But controlling the feet in a standard abduction brace depends on how much function there is further up in the leg. If they haven't got the function to extend the knees and to kick out against the splint, then I don't think that the abduction braces work as well. And so I would probably go for a standard ankle-foot orthosis. I might try with an abduction brace to begin with, because with that you can actually apply a bit more of the external rotation force to try and maintain a correction. But in a couple of the cases, it's a bit of an a la carte kind of thing, depends on the shape of the foot. But in some of them, we have used ankle-foot orthoses, little tiny ankle-foot orthoses attached to a bar, rather than using the boots and bar. You sometimes need to come up a little bit higher above the ankle with a splint that will control the ankles a bit better. That was that one, and that was one of the questions that was on the thing there as well. Urology then. So urology, the importance is to be able to empty the bladder. And if you have no control over the bladder, then you have the option of just letting the bladder void whenever you wish and wearing pads and dealing with continence that way. But that's a big social issue. And one of the things that most upsets children with no control over their bladder and bowels is smell, really, from voiding the bladder constantly into pads. And they don't want things to be overflowing or flushing or anything else. So our urologists will try to educate people to perform clean intermittent catheterization and perform that on a regular routine basis so they can keep control of the bladder and ensure that it is empty. A lot of the children, they will treat with a low-dose trimethoprim or nitrofurantoin urinary infection prophylaxis. For the more difficult ones to manage, then we have urologists who perform the Mitrofanoff procedure, where the appendix is used. You have an appendix vesicostomy. So the stump of the appendix is brought out to the abdominal wall, and that is attached to the bladder, and you can catheterize through that, and that makes things a little bit easier to control. The other option, the other thing is to keep the bowels empty, and to be able to do that with regular enemas or washouts and things. One of the things that our urologists and general surgeons do is an ACE procedure, which is an antegrade colonic enema thing, where a stoma is brought on the abdominal wall and you can wash through in an antegrade manner. That way you can be for sure before you go to school that your bowels are empty. You're not going to have any kind of embarrassing accidents when you get to school. But that's probably about my understanding of the general surgical side of things. How does that answer your question?
That was excellent. Yes, it was. And I think that we would all find that quite useful. Thank you very much. I think somebody's raised their hand.
Joseph Obanda has a hand up.
Okay. Thank you very much, Dave.
Not at all.
Yeah, I'm Joseph Obanda. Yeah, I'm a neurosurgeon. I saw the subject matter and I thought it would be very interesting to be a part of this meeting today.
Excellent.
Thank you. You've done a very wonderful. Yeah. Thanks so much. You've done excellently well, I must say. At my center here in Nigeria, in Abuja, last year I operated on about 52 of such patients. And what we usually will do will be following the releases or untethering or closure, as the case may be, the patients will be sent to the orthopedic clinic. So it's a quasi-multidisciplinary way of care. For urologists, for pediatric surgeons to look after the bowel and bladder, we're still maybe we still need some expertise in these areas. But the orthopedic component, yeah, they do a lot. I mean, particularly with Ponseti and then some serial manipulations. But as far as it goes, that's
I've lost you, I'm afraid.
Looks like we've lost him.
Still lost, I'm afraid.
I think we've lost him. It's got a bad network. If anybody has any other questions, please put your question on the chat box, or if you want to ask directly, please.
So I was wondering.
It's back again.
Oh, good.
And that's why I put up that one.
You got a question?
How could we get a true multidisciplinary of expertise in terms of orthopedic gather?
Sorry, I'm not getting you.
I think we've lost him again. I think I'll chat him and ask him what his question is. It might be a bit easier that way.
Certainly, and feel free to forward any questions on to me.
Sure. I'll ask Dr. Lawani to send him a chat and ask what the question, because I think he has a question actually. It was speaking towards a question. Yes, yes. I'll ask him what his question is.
I think he actually has something already in the chat box, and I'll just read it out. It says, what would be your advice to a center wishing to start such multidisciplinary approach to the care of spina bifida without the requisite experience by orthopedic, pediatric, and urology surgeons?
That's a tricky one. I think you need to find interested people to be involved in it. I'm not sure what the numbers are for each of your hospitals. One of the reasons that we have success with the multidisciplinary clinics in our hospital is that we have plenty of patients coming through them. We run a clinic once a month, and we have 12 to 15 patients each month coming along to spina bifida clinic. The other thing, though, that's really helpful for us is the charity. Spina bifida hydrocephalus Scotland is based locally to us. It's about 10 minutes away from Glasgow. And there are a number of very committed, very sensible, useful people who are there. And when one of the first things that I do when I see a patient on the neonatal unit is see whether they've had any contact with that charity. And if they haven't, then I'll ask their permission and I will refer them across to the charity. And the charity have liaison workers who will be in touch with the family. I think it is absolutely vital to put families in touch with other families who are going through the same things. You shouldn't have to relearn everything every single time. And so if you can sit with somebody who's got a child a year older than your own, and you can find out exactly where they bought their nappies, what kind of pushchair they bought, what they did for schooling, etc., etc., etc. I think that's at least as useful as any of us telling them anything. And to be able to discuss about what benefits they may be able to claim, how they can get assistance from government organisations, anything else. And the Spina Bifida Hydrocephalus Scotland Association have all of that. So SBH Scotland is the website for them. There's also a Spina Bifida International Foundation, which has a whole load of documentation that's out and point patients towards that. In terms of getting the expertise, then I think the urological procedures are very much the kind of procedure that can be performed by any pediatric urologist. They may need to go and visit an appropriate center that's got a high turnover of these things to learn them, but just the same way that any of us would go and learn an orthopedic procedure or other procedure. We'd certainly be happy to have anybody come and visit in Glasgow, and I'm sure that there would be other units elsewhere that would offer the same. Was that waffly?
No, it wasn't. It was very good actually. That's excellent. I think what he needs to find a urologist and a pediatric orthopedic surgeon that's interested, or an orthopedic surgeon that's interested in helping him with some of these problems, and that's what he needs to find. I think one can be created. He just needs to find.
Absolutely.
Yeah. If he has that kind of caseload, then he should be looking for people to support him.
Yeah, I'd have to say that the textbook for orthopedic management of spina bifida is one of the thinnest that I've on my bookshelf. Menelaus, the guy who came up with the Menelaus predictions for limb length discrepancy and everything else, orthopedic management of spina bifida cystica. I'm not sure if it's still in print, but it's a small, slim 150 odd page book, and it's got everything you need in it and easy to understand orthopedic kind of terms. I got mine on Amazon for 20 quid. And I'd strongly recommend that book.
Yes, that's supported. I've got one on my shelf. You can read it in 1 week.
Things have changed. Say again?
I said you could read that in one weekend. It's quite a nice.
Definitely. Yes, definitely.
Are there any other questions from any of our colleagues? If not, then I'll pass back the meeting to Dr. Lawani to wrap up and close. Thank you again, David, for taking the
Very
time
nice
out.
to speak to you. Thank you very much to everybody for asking me along.
Very nice.
Thank you very much once again. I suppose spina bifida is so niche, is why we're having this temperature in the house, to put it that way. Yeah. And I know even with myself, one of the things I have learned from you, from the brief time I've gotten to spend with your patients, is how, I remember telling you how destructive I thought spina bifida surgeries were.
Oh, absolutely. It is. It's a very, very different mindset. And I could see on the face of the fellow and the registrar who were with me in theatre on Thursday this week, after they'd spent several hours on Tuesday morning doing arthroscopic ligamentous reconstruction for somebody who had a knee dislocation. We just flipped our patient prone and took a pair of scissors to the posterior cruciate ligament and everything across the back of the knee, apart from the nerves and the Bertie blood vessel things. Then they looked a little green, but it is destructive surgery. You have to take away things. If you're going to do a tenotomy, don't just do the tenotomy. Take out a couple of centimeters of the tendon because you don't want it growing back.
Absolutely. So I think it's a different way of thinking, quite different from the so-called orthopedic reconstructions and repairs that we're used to. So I suppose that's different. I'm quite delighted that we have had a neurosurgeon in the house, and quite surprised as well at the number of spina bifida patients he says he's operated on in 1 year. Because if you had asked me, I would have said, no, we don't have that much spina bifida in Nigeria. But it's a large country. It's probably not surprising going by that and going by the statistics that you also put up earlier.
I was surprised at the numbers actually in the meta-analysis thing that I came across, because I thought we had most up in Scotland and in Ireland, but to be a variety of different reasons, I guess. I guess one of the things that will be different as well is how many are diagnosed antenatally.
Yes, I suppose
so. Everything can be in place when they're born.
Yes, because I really just didn't think we saw so many of them during training. But like I said again, the data is skewed because the neurosurgeons certainly see them more.
Right.
If there are no other questions, I suppose we can sort of go ahead to wrapping up the meeting slowly, but not before I say thank you very much to you, Dave, for just being your wonderful self.
No, you're wonderful.
And thank you very much for all the things that you have done in terms of teaching, and even about the work that we're doing on this platform as well. Thank you for being so eager and happy to give your time. And we will definitely call on you again. We're wrapping up the pediatric orthopedic sessions by the end of this month. And we've been going for about 3-4 months now.
Okay.
Yes, I suppose one easy thing to see is that we couldn't teach the whole of pediatric orthopedics for obvious reasons. And I would definitely ask you to see what you thought in terms of like structure of the syllabus and perhaps what to add on and how to stretch out stuff a bit more. That would be quite nice. Hopefully the next set of lectures should start from about the middle of next year. And then we'll just start the curriculum all over again. But I will definitely keep you posted. And definitely hope that you would be able to find time to do a bit of teaching on limb reconstruction, because I know that is your passion. There's so much we can learn. And if you ever want to come visit Nigeria, you of course have a standing open invitation. You're welcome anytime. I'm sure we'll definitely be able to find form it is for you to see. All right, so it's been wonderful having everybody in the house again today. We'll continue next week as well. Next week, we're having talks on cerebral palsy. And after that, on brachial plexus, and subsequently, we'll essentially just round up the set of pediatric orthopedic lectures and then move on to the hip and knee bits and so forth. Just to say for the residents that we will be sending out some kind of evaluation, not because we want a pass or fail feedback, but because we want to sort of see how effective the whole learning experience has been for all of us and how much retention of knowledge there has been, and perhaps even go a bit further to see how people think this will affect their practice. And also because we're constantly looking for more and more people who would be interested in giving their time to looking after children as well, because similar to what you have in the UK, it's the average resident just wants to do hips and knees and spine. So we'll be doing that, and we'll just take it from there. Thank you all, and see you once again next week. It's been lovely having all of you.
Thank you very much, everybody.
Thank you very much, David, again.
Cheers. Take it. Bye-bye.